Welcome back to Diabetic Foot Files, the podcast where we break down the science, the strategy, and the real life stories behind limb salvage, wound healing, and everything in between. Today's episode is a powerful one, and we're stepping into the amazing world of vascular medicine. And we know vascular is the lifeline of a diabetic foot. I'm joined by Dr. Jay Patel. Dr. Jay Patel is a Dallas native and board certified interventional radiologist with over 2 decades of experience providing minimally invasive image guided care throughout the Metroplex. He performs minimally invasive care for vein, vascular, and embolization conditions in North Texas. He is known for his technical precision, leadership in the field, and compassionate approach. Dr. Patel offers advanced vascular and embolization procedures that help patients avoid surgery and recover faster. He works at Texas Endovascular and he specializes in outpatient treatment for vein disease, peripheral arterial disease, uterine fibroids, benign prostatic hyperplasia, that's a mouthful, hemorrhoids, chronic joint pain caused by conditions such as knee osteoarthritis, frozen shoulder, and plantar fasciitis. His approach combines leading technology with patient-centered care, empowering individuals to restore comfort, confidence, and long-term vascular health. Welcome, Dr. Patel.
Thank you so much. Thank you for having me. I really appreciate it.
Great. So we're just going to dive into it. Dr. Patel, in your experience, how common is peripheral arterial disease to the general population?
Yeah, so this is a very important topic, peripheral arterial disease. It's oftentimes known as PAD. So PAD is a underdiagnosed condition. And what I mean by that is that we have patients that have PAD that just aren't going to their doctor, or if they are going to their doctor, they are not getting appropriately diagnosed. So it's something that we really need to raise awareness for. So that's why I'm really happy that we have this opportunity to talk about PAD. But to answer your question, as far as how common PAD is in the general population, it's estimated that about 10% of the general adult population has PAD. But when you look at the patient population over the age of 70, that prevalence rises to almost 20%. So as patients get older, it becomes a lot more common. And it's estimated that somewhere between 8 to 12 million Americans have PAD. And a lot of them are asymptomatic and don't require necessarily an intervention, but it's still important for them to be diagnosed, even if they're asymptomatic, so that we can closely, as providers, monitor them, see if they become symptomatic, make appropriate interventions, including lifestyle interventions as necessary.
Oh, wow. Okay. Dr. Patel, so let's I'm going to ask you, what happens inside the artery when a diabetic patient develops peripheral arterial disease?
Yeah, so essentially, PAD is an inflammatory disease of the arterial wall. So, what typically happens, and I'm going to throw out some scientific terms here, I'll try to explain it in a very easy to understand way. But PAD occurs when there's inflammation along the lining of the artery or the blood vessel. And that's typically started by having certain risk factors like diabetes, like you mentioned. Smoking is a big risk factor. High cholesterol and high blood pressure are risk factors. So if you have these risk factors, once the inflammatory process or inflammation starts, the inner lining of the blood vessel or the artery called the endothelium is damaged. And then cholesterol particles will build up in the arterial wall. And then that triggers a further inflammatory response where the cholesterol plaque or cholesterol buildup causes the artery to become narrowed and then sometimes blocked completely. So imagine traffic on the highways. I like to use the traffic analogy. And imagine if we had a 5-lane highway and the cars are going freely, that's a normal artery. But if there's a car accident, then the 5 lanes can go down to 3 lanes, 2 lanes, or even no lanes. And then a traffic jam builds up. And then that's kind of what happens with the blood flow inside these diseased arteries.
Okay. Wow, I really love that analogy. So, why do diabetics often develop below the knee arterial disease?
Yeah, so this is one of the most clinically important patterns in PAD. Diabetic patients have a predilection for tibial and peroneal disease. So that is below the knee disease, as you mentioned. So those arteries are below the knee, and several factors contribute to this. First, there's a metabolic abnormality of diabetes, which is hyperglycemia, high blood sugar, insulin resistance, and then dyslipidemia. Those three things primarily will create kind of a hostile environment for these smaller, more distal vessels. So these are smaller arteries compared to the ones in our thighs and our hips. And they're a little more prone to becoming diseased in diabetic patients because of the small nature of these arteries. And then, secondly, diabetic patients will develop something called medial arterial calcification that preferentially affects the below the knee arteries. And then there's just a generalized inflammatory environment in diabetic patients, which can include something called elevated C reactive protein and other elevated inflammatory markers. And then that promotes a more aggressive atherosclerosis in these vessels.
Oh, wow. I I really love this episode because you're seem you s- you're a great lecturer. So, what is the difference between macrovascular PAD and microvascular dysfunction when it comes to diabetics, and why is it so important to identify the difference?
Yeah, no, that's a great question. And it's a real crucial distinction that we have to make as physicians and providers. So, macrovascular disease refers to atherosclerosis in the large and medium sized arteries like the aorta, the iliac arteries, the femoral arteries, and the popliteal arteries. Microvascular disease affects the smallest vessels like the arterioles and capillaries, primarily in the feet and toes. And I know you see this on a daily basis. So in diabetes, both systems are damaged, but through different mechanisms. Macrovascular disease is primarily atherosclerotic plaque, so cholesterol plaque buildup, whereas microvascular disease involves thickening of the capillary basement membranes and loss of capillary density, and that can impair the autoregulation of blood flow. So I know that's a lot of scientific jargon there, but it just goes to show you how diabetes can affect those smaller vessels in a very different way than atherosclerosis can affect the larger vessels. And because you can successfully revascularize with the large arteries and restore pulsatile flow to the foot, that's great. But if the microvascular bed is severely damaged, sometimes these wounds that we see every day won't heal.
Mm. So, Dr. Patel, what are some of the screening protocols should clinicians use when it comes to diabetic patients or peripheral arterial disease patients?
Yeah, that's great. So for diabetic patients, screening for PAD should be targeted based on risk factors. So in 2025, the American College of Cardiology came out with a scientific statement along with the American Diabetes Association. And basically, what they recommended is screening even asymptomatic patients over the age of 65 that have had diabetes for 10 years or more. They should be screened for PAD. A lot of these patients will be screened by other providers for diabetic retinopathy in the eyes, diabetic nephropathy involving the kidneys, or diabetic neuropathy. And similarly, we need to screen for PAD. So, one of the most basic tests that we do that's non invasive to screen for PAD is called an ABI test or ankle brachial index test. And that involves placing a blood pressure cuff in the arm and also at the ankles and comparing the two. And if a patient has an ABI of 0.90 or less, that typically indicates the presence of PAD. So that's a good way of screening for PAD. However, there's another test called a TBI, which is a toe brachial index, and that can also be a good test to test diabetic patients for PAD. So a TBI below 0.70 indicates PAD. And then any patient that's symptomatic that has, for example, claudication symptoms or exertional leg symptoms, but with a normal resting ABI, you can do something called exercise ABI, which can unmask PAD. So what that means is the patient may be asymptomatic at rest, and they may have a normal ABI at rest, but when they exercise and have some exertion, that can cause their ABI to drop into the PAD range and can therefore unmask that disease.
Oh, wow. You made a really good point about the other departments that people focus on when it comes to diabetes. Like you said, the diabetic retinopathy and the kidney. But yes, a lot of people do skip over the vascular aspect. And that's pretty much one of the most important aspects. So I really appreciate that. At what point should a clinician or podiatrist or any healthcare provider refer a patient to vascular surgery?
Yeah, great question. So, in general, I feel like podiatrists and any other provider, they should have a low threshold for referral to a vascular clinic like ours for diabetic patients. First and foremost, immediate referral is warranted anytime a patient has rest pain or non healing wounds or gangrene or any signs of acute limb ischemia. These are essentially vascular emergencies. For patients with foot ulcers, early vascular assessment is critical because if you delay revascularization, then that's associated with slower wound healing and higher amputation rates, which we all don't want. So, anytime you have a patient with non healing wounds, gangrene, signs of acute limb ischemia, you should refer pretty quickly. For patients that aren't as severe or urgent, but they have abnormal ABI or diminished pulses in their feet or ankles, then that's still a good reason to refer to a vascular clinic. Essentially, what I would say is have a low threshold for referral because a lot of these patients, as I mentioned earlier, are asymptomatic and they have no pain at rest, or they may not think they have PAD or anything wrong with their legs. But if you, as a clinician, suspect even mild PAD, it's a good idea to refer. And then once they get referred, we'll do the consultation, the full vascular workup. Oftentimes that involves non invasive testing like ABIs, arterial Doppler, CT angiography, and then make the appropriate recommendations, whether that's lifestyle modification, risk factor modification, or in the severe cases, taking them to the cath lab and doing procedures like angiograms and interventions.
Okay. So, Dr. Patel, you said that a lot of patients are asymptomatic when it comes to peripheral arterial disease. Why is that?
Yeah, part of the reason is that the body has a natural tendency to work around PAD narrowing or blockages. For example, if you have a narrowing in your tibial arteries, sometimes the body's other arteries can compensate for that narrowing, or the body can form what are called collateral vessels to get around those blockages or narrowings. And the patient may still have adequate blood flow at rest to those parts of the body, like the foot, but it's when they start to exercise or walk that 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 compensation is not adequate and they start getting symptomatic. So a lot of the times they just don't walk if it hurts, if it hurts after walking a few blocks, they may not walk at all. And so they'll feel like they're asymptomatic at rest, which they are, but they just don't exercise like they want to or should. And so a lot of times they'll just be asymptomatic. But then when you do those provocative maneuvers like exercise testing, that's when you unmask, their true extent of PAD.
Okay. So, when it comes to the role of imaging, what imaging studies are the most useful? Because I know when it comes to certain patients or certain insurances, patients might have to not covered for certain things.
Yeah, that's correct. So the approach to imaging really depends on the clinical scenario. For most patients, the diagnosis is made with the ankle brachial index, the ABI, and that's still the best first line test. It's simple, non invasive, and can be done in the office. So those patients sometimes will reveal themselves as having PAD, but for those patients that have normal or borderline ABIs, but symptoms, then the exercise ABI testing can be helpful. But then sometimes, even if that's not diagnostic for PAD, but we suspect clinically that the patient has PAD, we'll resort to anatomic imaging. And those patients are typically those patients are the ones that we'll consider revascularization on. So the three main options for anatomic imaging are duplex ultrasound, CT angiography, and MR angiography. They're all non invasive. Duplex ultrasound is probably the easiest to do in most offices. CT angiography and MR angiography have to be done at dedicated imaging centers, but both CT angiography and MR angiography are very good tests, especially to look at the larger arteries in the pelvis, like the iliac arteries, which sometimes can be limited when it comes to duplex ultrasound. But all three, duplex ultrasound, CT angiography, and MR angiography, are great imaging modalities when it comes to looking for PAD, especially in those patients that are symptomatic or asymptomatic with a high clinical suspicion.
Okay. What role does neuropathy play in masking peripheral arterial disease symptoms?
Yeah, no, that's a great question. That's really important because neuropathy can make the diagnosis of PAD confounding and difficult sometimes because when the peripheral nerves are damaged by chronic diabetes or ischemia, patients lose their ability to sense pain and temperature and pressure. And that sometimes can mean that they don't get the pain and the symptoms that we expect them to have when it comes to diagnosing PAD. And so, what we see oftentimes is patients with neuropathy and PAD will often present with advanced disease, non healing ulcers, gangrene, or infection just because they never felt the warning signs.
Okay. I see. So, when it comes to treatment options, what are the first line treatment options for peripheral arterial disease?
Typically, the first line treatment options involve comprehensive medical therapy and lifestyle modification. So, first and foremost, if a patient is a smoker, we highly recommend smoking cessation. That's absolutely critical because it is the single most important intervention we can recommend. Secondly, a structured exercise program, something that's supervised preferably, is now what we call a class one recommendation, and that's covered by Medicare. So patients should walk at least 3 times per week for 30 to 60 minutes, ideally under supervision. And then third, aggressive cardiovascular risk reduction with statin therapy, for example, targeting LDL cholesterol below 70 milligrams per deciliter is recommended. And then fourth, blood pressure control to less than 130 over 80 millimeters of mercury is advised. And so those are some of the conservative therapies that we offer patients. A lot of our patients will also put on antiplatelet therapy such as aspirin or Plavix. That way their blood is thinned. So those are some of the conservative medical therapies and lifestyle modifications that we recommend for patients with PAD as a first line option.
Okay. And so when it comes to lifestyle modifications, how important is that? And what would that look like when a patient is first diagnosed with PAD and let's say they're diabetic, but also they have a wound on the bottom of their foot?
Yeah, lifestyle modification is absolutely fundamental. It's not even really optional. Like I mentioned, smoking cessation is the most critical intervention. Supervised exercise is really important. Diet and weight management also matter. A lot of our patients, we advise them to not only maintain a healthy weight, but follow a healthy diet, such as like a Mediterranean style diet, controlling portion sizes, etc. The challenge is that lifestyle modification requires a sustained effort and behavioral change, which can be difficult for a lot of patients because it's a big change for them. But that's where we have to provide the resources, including smoking cessation programs, supervised exercise facilities, nutritional counseling, regular follow up, just to support these changes, because these will make a big difference when it comes to patients and how they respond to PAD.
Okay. So when it comes to supervised walking therapy, how effective is that when it comes to peripheral arterial disease?
Yeah, it's actually remarkably effective. And like I mentioned, it's considered a class one level A recommendation now because the evidence is compelling. They did these large studies, we call them meta analyses, where they look at patients that underwent a supervised treadmill exercise program, and it was able to improve their maximum walking distance by 180 meters compared to the control groups. And that's clinically significant. It also improves pain free walking by 130 millimeters and a 6 minute walk distance by 30 to 35 meters. So, very, very important. Again, it's a class one level A recommendation. Patients that walk to a moderate to maximum effort level notice an improvement in their claudication pain and improvement in the time it takes from the point where they have pain to where they have no pain. So the recovery is faster as well. So it's really important. And the key message is exercise is medicine for PAD, and it should be prescribed as rigorously as we prescribe medications.
Okay. And so when it comes, we're going to dive into the endovascular. So, Dr. Patel, many people hear the term endovascular procedure. What exactly does that mean?
Yeah, so the endovascular procedures, that's our forte, if you will. That's our bread and butter. That's what we do as interventional radiologists. So endovascular can be a little confusing as far as the term. It means basically inside the blood vessel. So endovascular procedures are minimally invasive procedures performed through a small puncture in the artery, usually in the groin, sometimes in the arm, sometimes in the foot. And instead of making large incisions and surgically opening the artery, what we're doing is we're threading small catheters or tubes and wires through the arterial system to reach the blockage. Think of it like plumbing. We're working from the inside to clear the pipes. We're using several techniques, balloon angioplasty, for example, where we inflate a balloon to compress the plaque and open up the artery. Sometimes we'll place stents, which are metallic scaffolds to keep the artery open. Sometimes we'll perform something called atherectomy, which is where we use a specialized device like a laser device to shave or remove plaque. Sometimes we'll use something called lithotripsy, where we use basically sonic pressure waves to crack calcified plaque. And we can also sometimes use drug coated balloons and drug coated stents that release medication to prevent the artery from narrowing again. This entire series of procedures is done under x-ray guidance. So it's very precise. We can see exactly where we're going. And it's oftentimes just done with local anesthetic or what we call conscious sedation, which is just IV sedation. So patients are awake, but they're comfortable. Many can go home the same day. In our practice, all of our patients go home the same day. And it's a dramatic contrast to traditional open surgery, which requires general anesthesia, large incisions, and longer recovery times.
Okay. So when it comes to endovascular treatment, how should patients prefer that over open vascular surgery or consider that over open vascular surgery when it comes to peripheral arterial disease, saying that the doctor saying that you need surgical intervention?
Yeah, for the most part, endovascular procedures have replaced a lot of open surgical procedures. There's still absolutely a role for open surgical procedures like bypass grafts, bypass surgery. However, there are so many more endovascular options now compared to even 5 years ago. So the differences, again, are pretty substantial. Open surgery involves making incisions, directly accessing the diseased artery, whereas the endovascular procedures, in contrast, are just done through small punctures, just a few millimeters. And so procedures are very safe. Recovery is generally very short. and the outcomes are just as good as traditional open surgical procedures. So, for the vast majority of patients, endovascular procedures have become the first line treatment for PAD patients.
Okay. So in diabetic limb salvage, how important are endovascular interventions?
Yeah, endovascular interventions are absolutely critical for diabetic limb salvage. Diabetic patients with chronic limb threatening ischemia, as we call it, rest pain, non healing wounds, or gangrene, they, they need revascularization to save their limb. Without restoring the blood flow, the wounds just don't heal. And unfortunately, amputation is inevitable for a lot of these patients. So that's why it's critical that they have an endovascular intervention. The challenge can be, however, that these diabetic patients oftentimes will have extensive below the knee disease with severe calcification, making revascularization very technically challenging. But with modern endovascular techniques that we use, including the techniques that we've mentioned, they have made it possible to treat even the very complex tibial disease that we'll see in diabetic patients. And the goal is to establish direct pulsatile flow to the wound bed, ideally to the specific angiosome, as we call it, which is the vascular territory that supplies the wound. So that's our goal. And as I mentioned, these techniques are evolving pretty rapidly. And where we are today in 2026, we weren't there even 5 years ago or 10 years ago. And so the techniques are evolving to the point where we are able to successfully treat these heavily diseased, blocked small arteries below the knee. And the outcomes are just getting better and better.
Okay, that's great. So when it comes to endovascular procedures with diabetics, how quickly can the blood flow improve after a successful endovascular procedure?
Yeah, good question. Blood flow improvement is pretty much immediate after successful endovascular intervention. We have studies that used advanced imaging techniques that show microvascular blood flow, which is blood flow at the level of the arterioles or capillaries, increases significantly within minutes to hours after a procedure. The macrovascular blood flow through the larger arteries improves almost instantaneously. And you can see this, when we're doing the procedure, when we do angiograms throughout the procedure to see where the blockages are and then to see how the blockages have improved after our interventions. And so we see the macrovascular changes pretty immediately, but the microvascular changes, at the small arteriolar level or capillary level also are pretty quick to revascularize and show improvement.
Okay. So when it comes to restoring tissue damage, can endovascular procedures restore the circulation or reverse tissue damage?
Yes, however, it's dependent on the type and extent of the tissue damage. So, for ischemic muscle and nerve tissue that hasn't yet undergone irreversible necrosis, revascularization can lead to significant recovery. For those patients that have necrosis, which is irreversible, so the damage has been done and it can't be reversed, those patients won't really have the recovery like those patients that have not had irreversible necrosis. So, what I tell patients is, for chronic wounds and chronic limb threatening ischemia, revascularization is absolutely essential for healing, but it doesn't guarantee healing. And the wound absolutely has to have adequate perfusion, as we say, ideally direct pulsatile flow to the wound bed for it to have a chance to heal. But it definitely can heal. It just depends on the extent of the tissue damage.
Okay. So what complications can occur during an endovascular procedure?
Yeah, this is important for providers and for patients to know. Endovascular procedures are overall very, very safe, with major complications occurring less than 1% of cases. The most common complications are typically access site related. What that means is the site that we go in with our puncture, whether it's the groin or the arm or the foot, those are typically where we see minor complications such as bleeding or hematoma formation. And even that occurs pretty unusually, about 2% of the time or less. And most of these are minor, small bruises or hematomas that don't require any additional treatment. Sometimes you can get something called a pseudoaneurysm or arteriovenous fistula, and that occurs less than 0.5% of the time. But major complications like arterial dissection at the treatment site, arterial perforation, or what we call distal embolization of plaque or thrombus, that occurs pretty unusually, about 2% of the time or less. So the risk of major ischemia or vessel occlusion requiring additional intervention is less than 1%. And then long-term complications can occur, including something called restenosis, which is the most common issue. That's when the blocked artery, once it's opened up, becomes blocked again. That can occur up to 40% of the time in interventions involving the femoral and popliteal arteries within 1 to 2 years. And that's one reason we use sometimes drug coated balloons and drug eluting stents, which have reduced the restenosis rate. So it can occur, but it's not very common at all.
Okay. And so, Dr. Patel, can you tell us about patients whose limb you saved through endovascular treatment and where, if that procedure hadn't been done, where they possibly could have lost their leg?
I'm sorry, can you repeat that one more time? I'm
I'm
sorry.
so sorry. Yeah. I was wondering if you could tell us a story about a patient, a possible patient that limb was saved through the endovascular treatment.
Oh, yes, yes, yes. No, thank you. Yeah. No, we've had several patients where we've basically saved their limbs. There's one patient I remember, 68-year-old veteran. He had diabetes. He came to us with a non-healing ulcer on his great toe that had been present for 3 months. He'd be, he was seeing a wound care specialist and they were doing an excellent job of local wound care, but the ulcer just wasn't healing. In fact, it was getting worse. He developed some cellulitis around the wound and he was on his third course of antibiotics. His podiatrist, wisely checked his pulses, found them to be absent, and then sent them to us urgently. Excuse me. When we examined him, his foot was cold. He had no palpable pulses below the groin, and his ankle brachial index was 0.35, which indicates severe ischemia. The wound care team had been doing everything right, but without the blood flow, that wound was never going to heal. So he was told by another physician that he would likely need a below the knee amputation. We ended up taking him to angiography and found severe disease. His superficial femoral artery, which is in the thigh, was completely occluded or completely blocked. And he had a critical stenosis or narrowing in all three of his tibial vessels. So the artery that supplied the territory of his wound, the dorsalis pedis artery angiosome, was 90% blocked. So what we ended up doing is performing endovascular revascularization using atherectomy to treat the heavily calcified tibial vessels, followed by drug-coated balloon angioplasty. And with these interventions, we were able to restore direct pulsatile flow all the way down to his foot and specifically to the artery feeding his wound. And the change was dramatic. Within a few weeks, the wound started showing healthy granulation tissue, the cellulitis resolved, and then over the next 3 months, with continued wound care, pressure offloading, and diabetes management, the ulcer completely healed. He kept his toe, he kept his foot, and most importantly, he kept his independence.
Oh, wow. I do have a quick question. How long does certain procedures like that take as an outpatient procedure?
Yeah, they typically take somewhere between 1 to 2 hours for the procedure.
Mm.
And sometimes we'll stage the procedures. So if the patient, for example, has blockages at multiple levels, we won't try to open up all the blockages in one procedure. We'll open up one set of blockages in one procedure, see how the patient's doing, monitor them closely, follow them up closely. And if they're still having issues, we may bring them back for a second procedure or even a third procedure to open up other blockages. So we'll stage the procedure in that fashion because we only want to do what's absolutely necessary for the patient, and sometimes trying to open up all the blockages in one session can be too much for the patient. It can be a long procedure. It can be difficult for the anesthesia team as well. So we try to stage procedures sometimes just to make it easier for the team as well as the patient.
Okay. So let's say somebody has severe peripheral arterial disease and a diabetic foot ulcer. What how many stages would something like that consist of? Let's say the major ones are blocked.
Yeah, typically something like that would require at least two staging procedures. One would be, let's say, if they had a blockage in their thigh arteries, the femoral arteries, that would probably be the first thing we try to open up, because sometimes just by opening up the femoral arteries or popliteal arteries, that can restore the blood flow down to the foot and to any wounds. And if the patient is doing great, after just one intervention, that's perfect. We'll still follow the patient up closely. But if their wounds are slow to respond or not responding, or their symptoms aren't getting better, then we'll most likely bring them back and do a second endovascular treatment where we treat the below the knee tibial arteries and open those up. And typically, those two treatments will solve the problem for the patient. But sometimes we'll have to do a third treatment. And then, like I mentioned, sometimes these blockages, when they're opened up, they will recur a few years down the road. And so for those patients, when we closely monitor them and their symptoms start coming back, we'll do some non-invasive testing to see if they're having any additional blockages or new blockages or reformation of blockages. And then we'll oftentimes have to bring them back a few years later for re-intervention.
Okay. So when it comes to revascularization, what's the relationship between revascularization and infection control?
Yeah, basically they go hand in hand. If you have a patient that has, let's say, gangrene of the foot or toes and an infection, cellulitis, that is really difficult to heal if they don't have adequate blood flow. So, like that patient I mentioned, they were on antibiotics, 3 rounds of it with very little to no improvement. And that's just because they weren't getting blood flow to that part of the body, that part of the foot, or to that toe that was involved. And once the blood flow is reestablished, they're able to heal those areas and also, more importantly, clear the infection to where they don't get spread of the infection or worsening of their symptoms.
Okay. And also, I know this is a little back and forth. When it comes to the endovascular procedure, how does the recovery look for something like that for a patient?
Yeah, generally recovery is pretty short. Like I mentioned, we do these procedures with just sedation or local anesthetic. We do them through little punctures. So the puncture sites heal really quickly, usually within a day or two. And then the patient's restoration of blood flow is felt pretty quickly. So recovery is really just a few days. We don't want them to lift anything too heavy the first few days after their procedure. What we tell a lot of patients is don't lift anything heavier than a gallon of milk, because we don't want to pressure or strain the puncture site and cause a bleeding complication. So we'll tell them to restrict any heavy lifting, restrict any vigorous activities for a few days. But that's really all it takes for the patient to recover. And most of them feel a lot better after a few days.
Okay. So we're going to do a rapid fire, quick questioning because we're rounding up at the end of it. So,
Sure.
what is the biggest misconception people have about peripheral arterial disease, in your opinion?
Yeah, the biggest misconception is that if you don't have leg pain when you walk, you don't have PAD. And that's a big misconception, because studies have shown that up to 90% of people with PAD either have no symptoms or atypical symptoms that don't fit the classic claudication pattern.
Okay. So, what's one symptom that should never be ignored?
Yeah, absolutely. So any non-healing wound on the foot or leg, especially in a diabetic patient, should never be ignored.
If someone suspects they have PAD, what should they do immediately?
They should schedule an appointment with a primary care physician or vascular specialist for evaluation. Don't wait to see if the symptoms get better on their own. PAD is a progressive disease, so early detection allows for early intervention.
I do have another quick question. Is
Yeah.
there something patients can do to prevent peripheral arterial disease or to make
Yeah,
their outcome better?
yeah. Prevention is always ideal. And the thing that patients can do is the lifestyle modification behaviors that we mentioned. Walking is really good, diet control, blood sugar control, blood pressure control, weight management. all those things are critical. If they're smoking, of course, stop smoking. If they're diabetic, make sure your blood sugars are well controlled and well monitored.
Okay. And so, what message would you give to podiatrists or and wound care specialists working with vascular surgeons?
Yeah, really important. So, early vascular involvement is critical. Don't wait until a wound has failed to heal for months before getting vascular surgery or interventional radiology involved. Studies clearly show that delayed revascularization is associated with worse outcomes.
Hmm. Yes. I, uh, I I remember you talking about having a low threshold for referrals to vascular. Sometimes I felt like I referred too much because I have a feeling or theory. I just feel I've had so many patients who come in for diabetes and diabetic foot ulcers, and I would ask them, "These people, how long have you had diabetes?" They'll say like 15 years, 20 years, right? And I was like, "So who's your vascular doctor?" And they say, "What is that?" And I would be confused how the person could have it for so long and never was referred to the vascular department ever. So
Yeah.
I what I've been doing is I just say the moment you get diabetes, I think everybody should have a vascular referral at least once a year just to make sure that nothing progresses.
I wish more doctors were like you. Think it's oftentimes on our end, what we're seeing is, it's too late or it was delayed for whatever reason. And then our options become limited sometimes. And we would much rather see patients sooner than later. So again, like you mentioned, we want our referring providers like podiatrists and wound care physicians to have a low threshold for sending patients for vascular consultation. We want to see these patients earlier than later, because we can offer so much more when we can intervene, or whether it's lifestyle or procedures, when we can intervene earlier than later. And we just don't want things to get to the point where, you know, the damage is irreversible. And then they're oftentimes looking at an amputation. Our whole goal, and I know your goal as well, is to prevent amputations, whether it's a toe amputation or a foot amputation or a leg amputation.
Yes, that's what to tell. But I always tell people vascular has never done me wrong. Even if we're out of the scope of wound care and diabetes, I always even as a podiatrist, patients refer them to vascular because you'll be surprised. They'll come up for a follow up and they'll be like, "Oh, they found a Baker cyst or they found this or that," and they're like, "Nobody ever referred me to vascular and they fixed my pain." And I was like, "Oh, I didn't know." So I just feel like you can't go wrong with referring the patient to vascular. Either you find out you're good or
Yeah.
you find out that there's something that can be fixed. That's how I feel.
Right. Right. Absolutely. No, I completely agree. And again, that's why I say I wish I wish more providers and physicians and podiatrists were like you.
So, I have a quick question. Um, if if in your opinion, clinicians can remember one thing about peripheral arterial disease and limb salvage, what should it be?
Yeah. Just have a very low threshold for referring patients to a vascular specialist. Keep that in the back of your mind that this patient that I'm seeing, whether you're a podiatrist, primary care physician, or any type of provider, that vascular disease is very common. It's only going to become more common as the population ages. Have a low threshold for suspecting it and referring patients for it.
Okay. Yes. So thank you so much, Dr. Patel. What a wonderful, powerful conversation. Today we saw how the story of the diabetic foot is not just about the wound, it's about the most important thing, which is the blood flow behind it. Because at the end of the day, you can do the best you can when it comes to wound care, but if the vascular supply isn't there, healing is an uphill battle for that patient. And what stands out the most is how far we've come. Minimally invasive image guided procedures are no longer the future, they are the present. And we're giving patients something that once felt out of reach, a real chance of limb salvage, faster recovery, and better quality care of life. And for clinicians listening, this is your reminder always think vascular. I always say vascular, vascular, vascular 3 times. Always ask, does this patient have the blood flow to heal? And if not, who can restore it? And for patients, know this there are options. There are specialists like Dr. Patel who are changing the outcome every single day. And this is Diabetic Foot Files. This is what we're all about. And we're connecting the dots between the disciplines, elevating care, and ultimately saving limbs and life. Until next time, take care of your feet because he take care of you. And thank you so much, Dr. Patel.
No, it was my absolute pleasure. Thank you so much for everything you do. Thank you for having me. Thank you for being on the front lines and, seeing these patients and sending them our way, because if it wasn't for you, we would never see these patients. So we really appreciate all of your efforts.
Thank you so much, Dr. Patel. I hope to have you again on another episode.